Hello, this is Max Knight, and this is a comparison of active release technique and strain counter strain. Um, so just right off the bat, the procedures of how you would do these, the uh, active release, step one, you'd just palpate for any dense, taut, or nodular type of tissue texture. Then once you find that spot, you'll want to maintain that pressure over the treatment area that's tolerable to the patient. And while you're holding onto that spot, you can, as a therapist, passively, or the patient can actively move that targeted muscle into a lengthened position. So you're still holding on with your thumb, finger, or tool, whatever, and you or the patient is moving that muscle into a lengthened position. So as we do that, we go to step 4. You'll hold that muscle in the lengthened position for about 5 to 20 seconds. And then when you're done with that, you release. So you let go and bring that muscle back to a neutral position or a shortened position, and repeat. So an example of this would be, we could use the bicep, for example. So let's say we're kind of palpating with our thumb and we find kind of just a very dense, almost nodular type of texture, kind of just in the middle of the muscle belly. So we'll hold on to that with our thumb. We'll press into it. We'll get that pressure, and we'll press hard enough to where it's tolerable for the patient, but it's still good pressure. And then while doing this, so the elbow would be flexed right now as we're pressing in to the muscle belly. The bicep or the elbow will be flexed. And then for this first part, we'll say that I, the therapist, have my thumb in the spot, and I'll passively extend the elbow until the end range of motion. I'll hold for about, I personally probably hold for about 20, 30 seconds. And then I'd let go, and I'd bring it back into a shortened position, find that spot again, and then do it until we feel a release or relief of symptoms, or an increase in range of motion. So looking at strain counter strain, a little bit different here. Step 1 is the same, except we're looking for something a little bit different. We're palpating for a tender point, so that's not a trigger point. We're just looking for a tender, slightly painful, or discomfort in the muscle in a certain area, and it's going to be related to the dysfunction that we're having. Step 2 is position to comfort. So pretty much what we're doing when using this technique is the therapist is passively moving the patient into a shortened position to relieve that tender point. So it should be a position where they're not feeling any pain or discomfort. And once we found that spot in that shortened position, we're going to hold it for 90 seconds. So this is probably a lot different from other treatments where you'd probably do it for like 20 to 30, or for ART, be like 5 to 20. But for this, we're holding for 90 seconds. So after we're done holding for 90 seconds in that shortened position, the therapist will passively return the patient into a neutral position, or your starting position, which will most likely be a semi lengthened position, and then we'll repeat. So again, we can use the bicep, for example. We'll say we're palpating for a tender point. Let's just say it's right in the middle of that muscle belly. So we'll palpate it, we'll find it, And then we can either just, gently put some pressure on it just so we know where it's at when we retest after. Or you could just mark a spot with a marker or anything. So after we do that, we'll do the position to comfort. So we will flex the elbow passively. Oh, yeah. So that the bicep will be in a shortened position. And we'll hold that for 90 seconds if the patient feels a relief in discomfort or pain. And then after that 90 seconds, we will passively return that patient to a neutral position. So we'll just move it into position where the bicep and the triceps are mutually lengthened or shortened. And then we'll repeat. So before we repeat, we'll just palpate again and see if that point is still tender, and we'll just repeat until we have some sort of relief. And if not, we may have to look for another treatment. So that's how they kind of work. Similar indications for these in the literature is just musculoskeletal pain, tenderness, musculoskeletal tightness, and an overall treatment goal to improve range of motion. So the theory for the active release technique can be a little complicated if you don't have like a physiological background, but hopefully this makes sense if you do a little bit. So there's a neurophysiological theory, and that is that manual pressure can stimulate cutaneous and muscular mechanoreceptors in the muscle to inhibit the H reflex or the Hoffman reflex. This reflex stimulates muscle fibers and alpha motor neurons, and this pressure, like you're pressing in to someone's bicep. Like I was kind of explaining in the procedures, that pressure, that mechanical pressure you're putting on that muscle is thought to relax those alpha motor neurons. We're kind of just, inhibiting that pain stimulus. And then there's a biomechanical theory or biochemical, sorry, it's a typo there, a biochemical theory where there's a release of endocannabinoids, or EC for short, from a mechanical stimulation to reduce pain. And the endocannabinoids are chemicals in the body that are used and released to inhibit reoccurring pain signals that go straight to the central nervous system. The theory behind the strain counterstrain is a proprioceptive theory, is what they like to call it, where it's just a rapid stretching injury can stimulate muscle spindles, which can cause a muscle being stretched to contract and resist even more during stretching. And a counter contraction of the antagonist muscles occurs, causing the first contraction to release. So it's kind of like a cycle. Let's say your quads are being stretched a little too far, so then you get antagonist muscles, your hamstrings will then turn on, and it'll be like an on and off cycle. The proprioceptive theory continued. If we increase muscle spindle activity by passively lengthening the muscle, so if we're flexing our knee, so we're passively lengthening the quadriceps, and then we decrease muscle spindle activity by passively shortening the muscle. So then that means like the therapist would passively extend the knee to shorten that quadriceps muscle. The theory or the thought is that we will reset the muscle spindle activity to a normal neuromuscular activity level. So when we stretch our muscles, the muscle spindles inside kind of respond to the change in length. So if we're overstretching, the muscle spindles will say, hey, brain, we're gonna get injured here in a second. So that's where the brain goes, oh, okay, and that counter contraction comes to hopefully, stop things and make sure we don't get hurt. But both these theories, in the active release and the strain, counter strain, they're both theories still being researched and looked into. It's not clear on what actually is happening, but it's still something being looked into. So for clinical application, there's 2 studies found. One on the left is just an immediate effect of active release techniques versus a Mulligan bent leg raise in subjects with hamstring tightness. And then on the right, there is just the effect of positional release therapy, which is another name for strain, counter strain. So if you see that out there, those are the same. And it just looks at hamstring flexibility. So if we go over to the active release, our first point in this article, they were over 40 subjects split up into groups of 20, or 2 groups of 20, one group receiving the active release and 20 and another group receiving the Mulligan treatment. The criteria was the subjects had to have a lack of 20 degrees of knee extension. That's another typo there. Excuse me. And both groups only received 1 treatment. So it's looking for immediate effects after 1 treatment. And also the subjects were healthy individuals just with hamstring tightness. Point 2, the active release method. The subject is supine with gentle pressure along the origin and insertion of the hamstring muscle from stretching due to passive hip flexion with manual pressure over the muscle. Point 3 is a Mulligan bent leg raise. And they did this by having the subject laying supine with a flexed knee over the therapist's shoulder. The subject actively extends their hip while the therapist holds the hip in a pain-free flexed hip position for several seconds. They didn't really document or give numbers for what they did. So it's kind of hard to basically compare it to the articles they discussed at the end. And then point 4, the active release showed more immediate improvement in the sit and reach measurement and the popliteal angle measurements. So pretty interesting. But the only limitation to this is that they did not, one, again, like I just said, they didn't really give specific parameters. And 2, they didn't give a follow-up time at all. So they didn't say anything about like 30 minutes after, an hour after, 1 day after, that kind of thing. So it'd be interesting to see, it would have been more interesting to see if they followed up with that. On the other side here, again, we're looking at strain counter strain or positional release therapy. In this study, they had 17 males and 16 females that had to lack 10 degrees of knee extension. And this was a crossover design. The subjects were also randomized, but they did not say how many males and females were able to get the true strain counter strain treatment. But like I said, it's a crossover design. Each subject got 1 true positional release therapy treatment and 1 sham positional release technique treatment done. So these two treatments were done on each leg. So say your right leg got the true one, and your left leg got the sham. And then the second and final session, after a week with no home treatment or anything like that, the second session, they did both treatments, but on the opposite legs, just to see if there was a difference. So point 3, the true method. The subject was supine. The therapist passively abducted and extended the hip off the table. They flexed the knee to about 40 degrees and then internally rotated the hip and held for 90 seconds. For the sham method, they only passively flexed the hip to 10 degrees using hand positions at the hamstrings and ankle for about 90 seconds. They did not explain out what parts of the hamstring or the ankle. They were very vague on that. And then lastly, point 5, there were small changes in the popliteal angle and active knee range of motion seen in both true and sham treatments. And they concluded that there was no clinically meaningful effects with either treatment. A limitation was in the criteria lacking or having patients lacking only 10 degrees of knee extension, while other studies discussed that they used 15 to 20 degrees of knee extension as their minimum criteria for including subjects into the study. So yeah, I wonder if, I was curious to know if they were to limit their minimum lack of knee extension to be 20 degrees if they find better benefits. And they kind of noted on that as well. So the bottom line, comparing these two articles together, active release may be a clinically more meaningful treatment than strain counterstrain when treating people or patients with myofascial tightness or pain. So thank you for listening. If you have any questions, just let me know. Thank you.